from Morocco, and I just came to New York City for my electives. I'm so excited to have Dr. Kittleson with us today, and we're so excited to announce the release of your book, Mastering the Art of Patient Care. And yeah, thank you all for joining us on a very cold Sunday morning, and let's get started.
Amazing. So our storyteller today is once again Dr. Michelle Kittleson. I met her virtually last year through her famous hashtag Kittleson Rules. And I actually remember the first tweet that made me be sure that I needed to be closer to her. Let me show you the tweet here. Let me just share my screen. Where is it? Share screen. Okay, so this is the one. And it says, can you see? Okay. It says, this one is inspired by many amazing mentors. After a long auscultation, turn the pillow over. The small gesture providing a freshly cool pillow is a subtle way to offer comfort in a stressful time. Now adopted as hashtag Kittleson Rules. And I actually remember that I spent some minutes thinking like how detail oriented was that tweet and how I wanted to just be closer to her. And so we invited her for a subspecialty VMR last year, which was amazing. And then for a patient encounter burrow session. And it was in that opportunity that she told us that Mastering the Art of Patient Care would be released this year. So here we are. And so excited. So Mastering the Art of Patient Care is a collection of Kittleson rules, and I feel so lucky and honored for the opportunity of reading this book. While I was reading it, I could literally picture her talking to me and sense her humor behind the insightful jokes. And if someone asked me, what is Dr. Kittleson like? I would say that she has this sunny energy about herself. And it's easy to see that she's passionate not only about like medicine, but about people and life itself. And this is something that I've confirmed while reading the book. So Dr. Kittleson, thank you again for being here today. Would you like to introduce yourself? And I would love to know, what is the purpose of the book?
Thank you so much for that warm introduction, and thank you for the opportunity to celebrate the release of my book here with you. So I'm a heart failure transplant cardiologist at Cedars-Sinai in Los Angeles, and it is actually unseasonably cold here in Los Angeles as well, so greetings from another cold place. And my passion is patient care. There's nothing I love more than taking care of patients. I say that my job is basically 100% clinical and 10% research because I'm at an academic medical center, but I just love taking care of patients. And the reason the book really started in a way from Kittleson Rules. Kittleson Rules on Twitter actually started because I was inspired by one of my trainees who said, all this stuff you keep on saying on rounds, you should be putting out on Twitter, and inspired me to join Twitter and start. So instead of 4 to 6 captive trainees on rounds with me, now I could share my hard-won experience with more larger audience. And then many people on Twitter said, well, when's the book coming out? So that inspired me to put this together, not as a list of random Kittleson rules, but as an actually fully formed book with chapters about how you get through the early years and how do you approach a patient in difficult situations and how do you take care of yourself. And I think the book really follows two purposes. Number one, I have been blessed to have countless extraordinary mentors. And so much of medicine is an apprenticeship when you learn by doing. And I'm lucky that I got to model myself after amazing people, but it shouldn't have to come down to luck. It shouldn't be the people you run into that make you into a great physician. So I wanted to put all that experience somewhere where I could share the wisdom of my mentors with many other people. And the second goal is Mark Twain, or the quote is attributed to many, many people. One of them is Mark Twain, said, Good judgment comes from experience, and experience comes from bad judgment. But then and then there's another quote from someone who said, but life's too short to make all the mistakes yourself. So learn from someone else. So that's the other purpose of the book. Learn from the things I did wrong and how I learned from my mistakes, lessons to be a more effective clinician. And that was the second purpose of the book.
Amazing. I love that quote about just learning from other people's mistakes. I think this is why I love stories and storytelling in general, just because I don't have to make all the mistakes myself. And I actually have an infographic for the structure of the book. I'm going to share that with you, and we can just go through it real quick. So can you see it? Okay. So we start with part 1 and building your medical foundation. And here she talks about the first years of medical school, clinical years, and how to navigate through your career path. And then she discusses how to hone your clinical judgment and how to establish your medical style with practical tips and detailed illustrating stories, which is amazing because we can actually see examples of how things happen. And for the fourth part, she focuses on how to optimize the care of your patients and yourself. And the last part is about the joy of medicine. And today we'll highlight 3 chapters. As you can see here, we have a fire behind the name of the chapter. So we'll start with chapter 9, the tough conversations, and then being a woman in medicine, and then self-care. So I want to start with the quote, a quotation. So great science doesn't save lives. The correct equation is great science plus effective implementation equals life saved. Effective implementation requires clear communication and trust. And I believe that Umaima has a question about that. So Umaima, why don't you go ahead and ask her a question?
Thank you, Laura, for this beautiful introduction. This chapter was so important, and I wish it will be taught in medical schools from the beginning. My question is concerning the first part of that chapter about communicating effectively patient's prognosis and diagnosis and avoiding using medical jargon. My question is, if we are in a very busy setting and you have, for example, a 15 patient cap and they are all sick, how can we ensure that we are delivering the most comprehensive explanations to our patients without compromising the time that we will give to other patients and without compromising our own sanity and time? Thank you.
That's a great question. So let's talk about the inpatient rounding environment, where you're right, you have, say, 15 sick patients on a busy service. And so the questions are, how do you do it effectively? How do you do it efficiently? Because no one wants rounds to last for 7 hours, because then by the end of it, no one even remembers where they are or what they're doing. Because a lot of things have to happen on the inpatient service for trainees. You need to get the work done, meaning have an effective assessment and plan for the patients that's then implemented. And it's implemented efficiently so that the work moves on and the trajectory of the hospitalization progresses unabated. And you need to convey all of this to the patient. So I think there's a number of ways that can happen, just starting with rounds, to be honest. So meaning it's nice as the attending physician to have prepared in advance by pre-rounding yourself and knowing all the objective data and having your mental set of what you think the plan should be. So then when the attending physician meets with the trainees, rounds can proceed more efficiently and you're not searching for data that should have already been reviewed. Second, the trainees come to rounds prepared with their conception of a plan, which may be right, or it may be wrong, but you've put together with your clinical reasoning what you think should be done for the patient today, and rounds are a safe space to go through that and figure it out. And then I like the approach of the rounding becomes a one-liner and straight to plan by system without a reiteration. Now, the beautiful formal presentation is beautiful, where you go through the subjective and the objective and the vital signs and the physical exam and the laboratories and the imaging test results. But if everyone has already reviewed that, you can often streamline rounds by cutting straight to the plan, assessment, and plan by problem or system. And in that way, rounds get a bit more streamlined, but then every patient needs a conversation on rounds. And the question is, how do you do that efficiently, but still effectively? So one approach I like to take is on that discussion on rounds. It is, how are you feeling? And then, this is our plan for the day. And this is our plan for your hospitalization. And we know that there's a lot of questions you're going to have because you need to process this information. So why don't we give you time to process it, and then we will circle back for a longer conversation. And I think that approach often works very well, so you're not bogged down in a very long conversation with every one of the 15 patients when patient 15 gets short shrift because now you're running into noon conference and you haven't entered the consults and you haven't entered the orders. So you do that briefly, and then you can circle back later, and maybe all 15 are going to need to circle back, but maybe only 5 or 10 are going to need to circle back because maybe some of them are straightforward, but you have that sense then and I think that helps the patient too to have that 1-2 to get more information. So that's the one way I like to accomplish it effectively and efficiently. Tell me if I answered your question and other questions you have about that.
Yeah, you did. You perfectly answered my question. And you also reminded me of a tweet, I don't remember who wrote it, about like the switch they notice in the patient's, like in patients' reactions once they ask them, do you have any questions for me, versus what questions do you have for me? Because the second one implies that it's natural for the patient to have questions and they should just ask them away. So yeah, I just wanted to share this pearl. Unfortunately, I don't remember who wrote it, but yeah, thank you so much. You answered my question perfectly.
I love that quote, Umayma. I'm gonna remember that. And I have a question too. Actually, it's about the story of the patient with the lung mass that seemed to be, I don't know if it was your first or like most rememberable experience with breaking bad news. And I would love to know, like, what was your most valuable learning from that moment? And if you could just make a brief summary of the story, just so that everyone here knows what I'm talking about.
Absolutely. This was a lovely patient I took care of over a decade ago. A man, a middle-aged man who had advanced heart failure, needed a heart transplant, and part of the routine part of the transplant evaluation is making sure the rest of the body is well enough, there are no other contraindications in other organ systems, and one of those is an imaging test, chest, abdomen, pelvis, CT, partly for surgical planning and partly to make sure there's nothing hiding anywhere. Well, in this patient, something was hiding somewhere. There was a lung mass that was quite clearly radiographically consistent with lung cancer. And it was really just sort of bad luck that it happened to be in his left upper chest where his defibrillator head was. So even though he had 100 chest x-rays, it never showed it because it was somehow hiding in that. So, and it's that weird, there's a weird limbo when you know bad news and the patient doesn't know the bad news yet. And it feels so, so many times in medicine, it's really awesome to know the right answer and to get to the diagnosis. But then when you're in that place where you know something and you're the only one who knows it right at that moment, and you have to break that news, it's a horrible feeling in the pit of your stomach. And at the time I was quite inexperienced, and I hadn't delivered bad news. So I went to my mentor, one of my many mentors, and I said, I don't know what to do. And my mentor helped me put through a stepwise approach that I then applied to many other patients in how to deliver bad news. And this is covered in chapter 9. So step 1 is you gotta have a sense of what you're going to do before you talk to the patient. So it's, as my mentor put it, you don't just drop the bomb, you start the cleanup, right? The bad news is the bomb. You also need to have steps 3, 4, and 5 for them. What happens next? So in this situation, it was pretty clear radiographically that it was cancer. And I'm a cardiologist. I don't know what the first thing you do when you see a lung mass is potentially cancer. So I reached out to an oncologist colleague, the one that I would plan to refer the patient to. And I said, this is the situation. I'm going to break the news to the patient. But what happens next? He's like, well, it's need a PET scan and a thoracic surgery consult. But, would see me first and we can go through that. And I said, wonderful. Got a date and a time for the oncology appointment, within the next week, and I felt much better. So then the next step is, how should I tell the patient? Should I call him up and say, I want to talk about your chest CT, let's schedule an appointment? That might feel horrible. Now but I'm not telling him what I want to tell him about the CT, or just tell him over the phone, or now in the telehealth world, tell him over video. At the time, I knew it would be too nerve-wracking, knowing the patient as I did, to have to schedule an appointment. So I knew that a phone delivery would work well. This is in the days before video visit telehealth. Maybe I would have done that now. Kind of depends on how technologically adept the patient would be and comfortable with the video stuff. And so I decided to call the patient. Didn't want to make him wait and stew. The next is, what do you do when you deliver the news? And I am a big believer in always addressing the elephant in the room. Meaning, you don't say, there's a mass here, we're not sure what it is, I'll have you see a specialist, it could just be scarring, it could be maybe an infection, maybe it's cancer, we don't know. I really think that everyone's brain goes to the worst case scenario, and you've got to address the elephant in the room. It might really not addressing the elephant in the room might be comfort to you, because you don't have to say something that's uncomfortable or bad, but it's not the best thing for the patient. And so when I explain it, I say, there's a mass. I know the first thing you're thinking about is, oh my gosh, is it cancer? Yes, it very well may be cancer. And then you kind of sort of talk around that a little bit, because then all the patient will hear in their brain is just a whooshing sound, right? It's just their heart pounding. It's awful. So you kind of give them time. Sometimes they're going to have questions. How did this happen? How come I didn't know about it sooner? So you kind of go through that, and you feel the patient out. Sometimes the patient will say to you, great, what's the next step? They are planners, they're making a list, they've got a notebook out. Other ones are just kind of blinking and stunned. You kind of have to feel them out. When are they ready for the next step, which is, what's our plan? What are the next steps? And then at that point you say, I'm not a specialist, but I've spoken to a specialist in this area. This is what we need to do next. Here's the date and time and location of the specialist. Their office is going to call you as well, but we need to get you in. We need to figure out what we do next. And after that point, I've kind of gone as far as I can go as a heart specialist when I've discovered a lung mass. And then but I always end with a promise. Now, the promise is not that things are going to be just fine, because that's a cruel promise. The promise is, I know we don't have all the answers, but I promise you we will make a plan to get the answers. And the second part of the promise is, I promise I'll be honest with you. Whether the news is good or the news is bad, I will always give you the respect and consideration to tell you exactly what we're dealing with. And I will not abandon you. I am still your doctor. Maybe we took transplant off the table. I am still your doctor. And then I think it's very helpful to circle back in so many emotionally charged situations. To see, even on rounds in the morning, you circle back. With patients, when you give her bad news, you circle back within the next day or so. Hey, I think many more things might have come up. Can we talk through this some more? Where are you now in the process? Did you hear from the oncologist, et cetera, et cetera? And I think those steps of knowing your plan in advance, lining up some ducks in a row when you're giving the bad news, making sure you clearly, explicitly go through the worst case scenario, elephant in the room with the patient, because if they will, so you better. Give them a time to process and then go into the next steps. Make a promise to always be there, always be honest, and help them get answers, and then circle back. And I think it's awful to deliver bad news, but it's worse to do it badly. And I sort of joke with patients, I'm a specialist in giving bad news. And that's okay, because this is my role to help you through this process.
I love this. While I was reading it, when I read that not addressing the elephant in the room is actually providing more comfort to myself. This is something that I always remember now. just because we feel like we're doing our best when we're not saying that it could be cancer, that probably is cancer, but this is only better for, well, not for anyone actually, but we feel like it's better for them, but it's not. And something important that you said is that sometimes when you're circling back, being present can be enough. So for that patient, you had that interaction with his wife,
Yeah.
was it?
Yeah.
Yeah, and like you were there, and this was like enough for her, like for your relationship. And like this is so important to know that sometimes there is nothing else that you can do as the doctor, but you can be there and just help build the trust that you need in order to communicate and take care of the patient. So I love that chapter actually. Thank you for that answer.
I ran into the patient in the elevator a few months later, and we love all our patients, of course we do, but there's sometimes when you just feel like, gosh, I could hang out with this person even if I wasn't their doctor. And the fact that we have a manual, an orientation manual we give to potential transplant candidates about the process, and he found some typographical errors in it that no one had bothered to read closely enough to find. And I was like, you're my person. You're like a hidden copy editor. So am I. We just had this great detail-oriented bonding moment. And, it was astonishing to me seeing him in the elevator those few months later. His wife was pushing a wheelchair at that point. He was jaundiced and fatigued and bald and emaciated. I mean, it was astonishing what had transpired in just a few months. And his wife had aged, but they were so grateful. And I'd done nothing medically, but exactly as you said, they felt that I was still part, as awful as it felt for me to watch that, they took comfort from knowing I was there and that I cared, and that makes a huge difference.
Yes, it really does. Does anyone in the chat has any questions? I'm not really looking at the chat here. If not, I think we can. Okay, so Leah said something. Let me just.
Yeah, I just want to add that by delaying addressing the elephant in the room, especially to cancer patients, you are really robbing them from precious time that they can make a plan, time to process the news with their families, time to spend doing things that are important to them. So yeah, what you said, Dr. Kittleson, is very, very important. It's not a pleasant thing to do, but it's necessary and the right thing to do.
And it's always backed up with enough medical facts, right? I think especially early in training, much of what you do might not be directly yourself being the one delivering it. You may be watching someone more experienced and you do it, whether a more senior resident fellow or your attending physician. I think you can also learn by, did they do it well? Did they not do well? You learn just as well from the good examples as the bad examples. But the key, I really think, is getting as many medical facts as you can possibly get. And so even if it's not your area, and especially early in training, nothing will be your area, you have enough ammunition to provide the patient with that plan, with those next steps, right? That's the cleanup, not just the bomb, but the cleanup.
Yes, this is, I'm sorry. I think this is what Leah is saying here in the chat. As a student, I have not yet been in the position to break bad news to a patient, but it is so helpful to hear these tips and experiences. Also, the point that even just being there is something we can offer the patient when we might feel helpless otherwise in the situation. And I echo her thoughts. Yeah, I love this. So just go through chapter 11 now, which is being a woman in medicine. And I want to start with a quotation again. Nearly 50% of all US medical school students are female, but as of 2016, only 12% of board certified cardiologists are women. This is relevant data. This is shocking. And I wonder why that is. Do you have any, this was not a question that I wanted to ask, but thinking now, do you have any hypothesis for why does this happen?
Yeah, I mean, there's a lot of conversations going on about why are women historically underrepresented in certain fields, including cardiology. And it probably comes from a lot of different sources. It may come from the perception that cardiology is more friendly to men professionally, maybe also personally when it comes to work-life balance. It may be related to the lack of role models, like I don't see any women doing this, so maybe I can't do it as well. It may come from more explicit discouragement on the part of mentors who maybe discourage women because of issues of work-life balance. So it may come from many sources. I can only speak to my story, and I think the reason that 12% never registered with me or bothered me, or as I was kind of raised by my parents to sort of ignore the fact that I was a woman, or accept the fact that I was always going to be, a minority in medicine. My mom, as a physician, I guess I had a female role model, had always said, listen, just accept it. You're going to have to work twice as hard to be considered half as good. I mean, everyone's heard that aphorism before. It was sort of ingrained into me, this no matter what, try your hardest. So no one's, if they judge you based on the fact that you're a woman, there'll be nothing to judge because you will have always worked your hardest. And then prepare for disappointment. And then if it doesn't happen, you'll be happy. And if it does happen, so what? You know in your heart that you've done the right thing. Judge yourself by your actions, which are hard work, and not the outcome of someone else's reaction, which you can't control. So I think that's why my personal journey has not been fraught by a lot of self-doubt, simply because I was raised with that strong work ethic by a strong female role model.
Yeah, I actually echo that feeling of or like that mental what is the word for that? Mindset, that's the word. Like just doing your best and actually expecting that maybe it's not gonna be enough. Like just because we're women, and it's so unfair and annoying. But my question is actually about motherhood, and I think Umaima's questions is also about that because we want to be moms. Umaima, do you want to ask your question first?
Yes, I have a question. I'm not a mother yet, but sometimes I feel like being a mother is very, very penalizing for women, and it sets them backwards a lot in their careers. They start like experiencing new types of harassment, new types of discrimination. And my question is, how can we best address that, especially when we are somehow in the bottom rank of medical education? You're still a medical student, you're still a resident, you're not really in a position of power to change things. But at the same time, you also have your family goals. How can we like make both combine and speak up? And my other question is, as an IMG, I will be hopefully interviewing next year. And in the Q&A section, I'm thinking about asking questions about maternity leave and stuff, but everyone is like, no, that's going to be a big red flag. But at the same time, you have to be yourself and you have to be honest about your priorities and your goals. So yeah, can you like lighten us on that? Thank you.
Great questions. So, I talk a bit in chapter 11 on the right time to have kids, which is basically now or never. I mean, there's never a right time. I think about having children sort of like ordering an LP. So like if you think about an LP lumbar puncture, you should probably get a lumbar puncture. That's like the clinical saw in medicine. And I think that sort of applies to kids. If you're thinking about it, it's probably the right time. And there's never a good time. There's never a bad time. It's a kid, right? What are you going to do? But I think there are 3 criteria that make for most effective parenting, and this is what one of my mentors told me, and 2 out of the 3 criteria are really essential to make professional parenthood work. And it's, you need a flexible and supportive spouse, dependable paid childcare, family members who are nearby and willing to help. And if you have 2 of those 3 things, you will be able to make it work. Without that, I think it's really, really hard. So as best as you can do to fashion some kind of a support system, which contains 2 of the 3 of a spouse, family, or paid childcare, you can many times make it work. Now, but the next step is, how does that impact your career? And I think there's two answers to your questions. I think many women who have been surveyed in professional fields do feel that their career sometimes slows down, their career trajectory slows down with motherhood. And the question, I think, becomes how much of that is a systemic policy issue that you and I cannot change, at least right now, though we can be part of organizations to affect that change, and how much of that is on the level of a small level, the microcosm of you in your professional environment. And when we think about you in your professional environment and the impact motherhood, parenthood has on the career trajectory, if it slows down the career trajectory, there's two reasons why that could happen. One might be you just don't want to do more than you want your career trajectory to slow down. And that was me. I felt I have 3 beautiful, perfect children, and they're even more perfect when I'm not with them and doing a lovely podcast interview in peace. But the issue is, when you're pregnant, when you're taking care of an infant especially, life is so overwhelming. And I absolutely consciously took a back seat away from anything that did not involve keeping my children alive and keeping my patients alive. Those are my 2 priorities. I said no to every meeting. I said no to every talk. I was lucky enough to have wisely chosen a supportive work environment where that was okay. I picked a profession where patient care was going to be my primary goal, because that was always my passion. So if I said no to the extras, and I do believe that keeping my patients alive is a hugely important priority as much as my kids, so I felt very like what I was doing was worthwhile and important, and I could say no to the extras, and I was supportive. There's a second reason, I suppose, why your career trajectory could slow is not that in your microcosm, not that you wanted to slow down, but you feel you're being passed up for opportunities. Oh, she's pregnant, I shouldn't give this to her. Or, gosh, she's got a little kid at home. There's a perception that you feel is unfair and unwarranted. In that situation, like I said, the bigger societal systemic issues you're not going to solve for your microcosm, but that's the importance of role models, mentors, sponsors, allies. So the hope, and they don't necessarily have to be female, though many times they will be, but to have a mentor that you trust, where you can go to and say, I was not invited to do X because I'm pregnant and I really want to do X. Can you help me navigate a situation where the next time X comes along, I can be considered because it's very important to me? So I think on a smaller level, you have a safe space and a trusted mentor you can go to. And maybe they're not even someone at your institution. Maybe it's someone outside that you just trust, that you can talk it through with, and they can help you put together a plan of who do you approach and how. So that's to answer your first question, is what do you do when your career trajectory stalls because of parenthood? And as I said, if it's an internal decision that you have enough on your plate and you can't take any more, you should 100% be at peace with that, because I like to say that your priorities are right because they're yours, and comparison is the thief of joy. It's, patients come see me in transplant clinic and they'll say, so-and-so in the waiting room, I could overhear him, he's running 5 miles a day and I'm not. I'm like, come on, you don't know his medical history. Why are we doing this? Don't stop comparing yourself. And it's the same thing. Everyone has a different timeline, and you might achieve everything, but just not all at the same time. But if the second is true, where you feel that you are having external pressure that is impeding your progress, then you have to find a trusted mentor, colleague, sponsor, ally in a safe place to talk it through with. Now, your second question was, when you're going on interviews, do you ask about maternity leave? So there's a saying, another saying, perfect is the enemy of good, in the sense that in a perfect world, yes, you would ask that question and you would not be thought badly of because of it. But then there's the real world where you just don't know, because these people are essentially strangers to you, meeting you, potentially even over a Zoom screen, and they're going to have a very small window of time to subjectively assess your fit for their program. That doesn't mean you can't get the answers. The question is, who do you ask for the answers? And oftentimes on these residency, fellowship, interview trails, there's opportunities to meet with other trainees in the program. I think it's reasonable at that point to say, hey, any of your trainees in your program have kids? And if they do, how do they navigate it? You might not explicitly say, what is your maternity leave policy? Because my sense is that the ACGME, the American Council on Graduate Medical Education, probably has some policy. But it would be more useful just in the sense of the trainee says to you, oh, no one in our program has ever gotten pregnant. It's too intense for that. Or, oh yeah, we let 3 people out last year. We made it work and the chiefs are great and we figured things out. So I think you just get a flavor by asking that about what the program's like.
Thank you. That was super helpful.
Yeah, you actually answered my question too. I was gonna ask about the right time, that you said that it doesn't exist, but I wanted to know, like, what do you think it takes? And you just addressed that. So thank you.
You know, I think, and I'm glad, because I think that's important, but I think a lot of young moms come to me, and I love the experience of counseling young moms in medicine, because honestly, I look back so fondly at that wonderful, wonderful time of being pregnant. Like, it's so exciting. Plus, it's so efficient. You're always doing at least 2 things at once. I'm rounding and these cells are multiplying. I mean, it feels very cool. And I remember once I had a mom email me. She was about to start our advanced heart failure transplant cardiology fellowship. So she was a fully fledged cardiologist, was going to do an extra year with us to train. And this is probably about a decade ago. And she emailed me, this fellowship starts in July. She emailed me probably like in the spring after she'd gotten the position and signed the contract, whatever. And she said, I'm so sorry, but I just found out I'm pregnant and I'm due in November. And I didn't know when I interviewed. And I'm so honored. And I was like, oh my gosh, I emailed her back. And she's like, my husband, I've been trying for so long. We didn't know what's going to happen now. I emailed her, I'm like, congratulations. This is amazing. I'm so excited for you. Don't worry about it. We'll make it work. Patient care. We love our fellows, but we can take care of patients without them. We will make this work. And actually that year turned out she delivered her baby in November, and our other fellow, another lovely woman, was getting married in India and had scheduled her wedding during the exact same time. So we had a 2-week period where we had no fun, and one was getting married and one was having a baby. What could be more wonderful? It's like, come on, we're attending physicians. We can take care of patients without our fellows. So I think absolutely, there's never a right time to do it. But the fears, and so I got off on a tangent because I love talking about young moms, but the fears that they always come to me with, there's 3 fears that I cover in the chapter. Number 1, you won't remember how to be a good doctor after you have a baby, because whoa, it's a lot, and all that sleep deprivation, it's way worse than NICU call. Not to scare you away, but it's way worse than NICU call, because there's no duty hour requirements. And the baby is just like a blob to begin with. Eat, poop, sleep, and you don't get any love for the first few months. So that's the first fear, is you're going to forget to be a good physician, because your life's changed so much. And my mom had a harrowing delivery with me. She had eclampsia, she had seizures, help, the whole deal. And she told me when she went back to work as a pathologist, she was terrified. She's like, I'm not going to remember how to read a slide. And somehow her boss and mentor intuited that and said, hey, read these slides for me. And she read them all. She got them all right. She's amazing. And he then told her, those were the trickiest slides ever. And I just gave that to you as a test, not for me, but for you to prove to yourself you're just fine. And I thought that was really amazing for him as a mentor, but also just to know, your brain's still, you're going to be fine. Number 2, another unfounded fear is I work so much the baby won't even know who I am. But there's just something about these babies. You remember, eat, poop, sleep for the first few months, warm blob, it's going to be fine. But there's just something about being a mom and just being there. And even for the first year of my kid's life, I think our nanny and my husband probably saw the kids more than me, but they love me and I love them. That just doesn't happen. Quality time, not quantity, once they get older. And then the third fear many young moms have is they'll just never get it together. Like, life will never feel sane again. You'll never remember how to brush your teeth and shower in the same day ever with a new baby. And it just doesn't happen. You form new systems and you put together schedules and you have help. and it comes together. So yes, there is no right time, there is no wrong time. Spouse, family, paid childcare, that combination will make it work, and you don't worry. Many have done it before. You find a role model, mentor to help you through that process.
I love this because I have all of those fears that you just mentioned. And like, I don't even have a partner yet, but it is one of my biggest dreams to be a mom. And I always felt like motherhood and like medical lifestyle is just, you're like oil and water. So it is really comforting to hear all of that from you. We have a question in the chat. What advice would you have for women medical students interested in pursuing a career in cardiology?
Yeah, I think I'd have the same advice, honestly, for any medical student interested in any field, which is it's amazing to know so early what your passion may be, but remember that training is so broad, and to absorb every bit of it. I actually didn't know I wanted to be a cardiologist really midway through residency. And so I think it's okay not to know. It's also okay to expose yourself to a broad array of things. But then I suppose the next part of that question would be, well, cardiology fellowship applications are very competitive, and that's true. And oftentimes a good way to distinguish oneself is by doing research in the field. So identifying someone at your institution who's involved in research. There's also programs through places like the American College of Cardiology that have specific designed mentorship programs for early trainees who are interested, and that can help you enter the field at an early stage and distinguish yourself to strengthen your application.
I love this. Thank you for your question, Gurbani, and thank you for your answer, Dr. Kittleson. So now we just go to chapter 12, self-care, and I'm gonna let Umayma ask her question just because we're kind of running out of time and we still have the clinical reasoning part. So Umayma, go ahead.
Thank you so much, Dr. Kittleson, for all the answers. They are so helpful. My question is a little bit broad, but as someone who advocates for clinicians' wellness and doctors' wellness, how can I not come across as lazy? Because sometimes when I discuss this with some doctors, they are telling me, oh, but if you don't want sleep deprivation, why did you choose medicine? If you don't want burnout, why did you choose medicine? And sometimes I feel like we have to choose between self-care and our mental health and our passion for medicine, and it doesn't feel right. We don't have to choose.
Yeah.
What do you think?
It's such a good question. And I think the root of that question is why do we need self-care? We need self-care to avoid burnout, right? We need self-care so we can still consider medicine a joyful profession. So the question is, what do we need to do to maintain our joy in medicine? And I'm a big believer that all of us who choose medicine aren't afraid of hard work. It takes a lot of hard work to get into medical school. There's a lot of hard work to be a resident. What we really want is our work to be valued and appreciated, and we want some measure of flexibility and autonomy. I'll be the first to tell you that in training, that's really, really hard. But the flexibility and the autonomy, but the value and appreciation should be there. And then how does that manifest for a trainee? I think it's the ability to go to work every day and to feel like you've made a difference and done something important. And part of that's a self-perception. I think I am talking too much because we're almost running out of time, but I'll tell one quick story, which is I remember leaving the hospital one day with one of my co-residents after like a really horrible shift, so maybe one of those 30-hour, 36, whatever we did back in the olden days. And we're trudging in the icy sidewalk to our cars to go drive home. He's like, it was like the worst day ever. And I was like, really? Kind of, but you know what? I had to write out 20 prescriptions for this patient that's going to be discharged because we used to write them out in the old days. And at least I did that. At least she has her prescriptions. I did something. And it's just sort of like a glass half full, half empty thing. I think we take for granted that every little action we do actually does help a patient. So part of it is self-perception. The second lesson in that story is the value of venting in a safe space. And I would not have made it through the the craziness of residency and fellowship without my colleagues, so you have those colleagues, and as you vent in a safe space, you often can differentiate, what do I just need to get out and feel better because I have someone to talk to who understands me? And what's a real problem here that we need a solution for? And then if you identify those, then it's finding those mentors, whether it's someone in a higher of echelon of leadership in your program to talk through that issue. But I really think self-care, it's not about vacation time. It's not about, a yoga retreat. It's about feeling that your work is meaningful and which can be a self-perception, and having people to go to when you feel that you're just at the end of your rope and you can vent and come up with, and then figure out, what do I actually need a solution for?
Yeah, thank you.
I love this. It's really important to acknowledge that we are always doing something useful for the patient. So this is part of self-care. I love this thought. Okay, so now for the last part of our session, Dr. Kittleson has a case of a patient who underwent a TAVR and had a really rare complication. And I would love it if you could tell us the story and share what was your biggest learning with this experience?
This is an example of learning from my mistakes. It's also an example it's better to be lucky than good, because I did not come up with the right diagnosis when I should have, but the patient still did okay. This is a lovely older woman who had severe aortic stenosis, underwent transcatheter aortic valve replacement, a TAVI, and she did great. They did an angiogram before and it looked fine. She went home. A few months later, she's like, my arms hurt. If I use my arms too much, like I'm folding laundry, it gets kind of achy, but if I drink cold water, I feel better. And I was like, I think you're fine. And she called again about it. And I'm like, I think you're fine. It doesn't sound cardiac. It's not exertional. So go on your way. A few months later, her husband passed away, and she came to the hospital with a lot of chest pain and shortness of breath. Her echocardiogram, she had an EF of 25%. It was normal before. Apical ballooning looked very much for all the world like a stress cardiomyopathy, Takotsubo, maybe precipitated by her husband's death. But that's a diagnosis of exclusion. You have to do an angiogram to rule out at left main LAD disease before you can say, oh, it was just anterior wall motion apical ballooning from stress cardiomyopathy. And lo and behold, she had a 99% osteo left main stenosis that was mechanical from the TAVR. So deployment. And that's an incredibly rare situation. It's a case report type situation. She got a stent. Symptoms got better, her echo got better, she lives her life. I see her, once a year in clinic, she's doing great. But I missed the diagnosis. And I look back on that, I'm like, what are the lessons I can learn from the fact that I missed this that I can help other people? Number one is, oftentimes when a patient reports symptoms to you, you need to think about their personality. Are they the kind of patient that calls you every single time they have a symptom, or do they never call you? And she was one who never, ever called me. I actually went through the chart looking at telephone encounters. There have been none for like 10 years until this time. Okay, that should have been a red flag. The second thing that can be helpful is opinions from corroborating evidence, meaning a patient may tell you something, but maybe their family members have a different story. And because the patient minimizes, and her daughter said, oh yeah, it wasn't just with folding laundry, she could barely walk across the room. And I was like, oh my gosh, red flags, red flags. I should have tried to tease out the symptom more. The other can help helpful is context. Where does the patient show up, right? If the patient shows up to the ER with chest pain, it takes a lot more activation energy to go and to put yourself into the chaotic environment of an emergency room rather than calling your doc and seeing them a week. That patient instinct that something is wrong and I need an ER is often very helpful to triage the severity of a symptom. And you also have to figure out where you are. Like, was I in the headspace that I was just super overwhelmed, that I'd had enough and too many other things on my to-do list, and her symptom wasn't that concerning, so I just brushed her off? Did I give her the focus she deserved? And then I think it's so important to try to put ourselves in patients' shoes. They come to our office, they rearrange their entire day to see us. So it might be patient 15 out of 20 for us, but it is their big thing of the day. And try to remember that and reset your mind every time you go into a patient room to give them the attention they deserve. And I think those points are incredibly important when you interpret the symptom in the context of who the patient is, other opinions, the other contexts, and where you are to reflect, are you giving that patient everything they need?
I love the fact that the way the patient tells the story can be really different from the way like the mother or the sister tells the story, and then you can have a better sense of like what the actual symptom is. And this is something that I'm gonna pay more attention from now on. And yeah, actually, how do you say that? It's Tav? How do you say
TAVR.
TAVR?
TAVR or TAVI.
TAVR. Okay.
Actually, the clear term is TAVI, TAVI, because it's a transcatheter aortic valve implantation. So the guidelines call it TAVI, but yeah, just a transcatheter aortic valve.
Yeah. Yeah. Okay. So I've created an infographic that I really want to share, just highlighting some complications that may happen. One second. Can you see it?
Oh, beautiful.
Ah, thank you. Okay, so transcatheter aortic valve replacement is the mainstay treatment of symptomatic severe aortic stenosis, and it is an alternative to surgical aortic valve replacement. So here you can see that we have three different approaches: transfemoral, transaortic, and transapical, but the most common approach used is transfemoral approach. We'll highlight the complications here just because it is the story illustrated by Dr. Kittleson highlights a complication. So vascular access complications most commonly occur at the access site, and bleeding and hematoma formation occurs most frequently. And an interesting fact is that failure of a closure device, which is adopted to prevent vascular access complication, is the most common cause of a major vascular complication. Now, device landing zone rupture is a rare complication with an overall mortality of up to 48% and can be as high as 75% in cases of uncontained rupture. And the most frequent anatomic site of rupture is the aortic annulus, involved in 2/3 of cases. Device embolization accounts for approximately 45% of emergency cardiac surgery in patients treated with transcatheter aortic valve replacement. And embolization usually happens acutely and intraprocedurally. So now my favorite, just because I'm a neuro lover, stroke is another important complication with a high risk of 30-day mortality. But subclinical new cerebroischemic lesions are much more common and can be identified in up to 80% of patients. It is interesting to know that there is a bimodal pattern of distribution with up to 50% of events occurring within the first 24 hours after the transcatheter aortic valve replacement, dependent on clinical and procedural factors. And there is a late phase that occurs more than 10 days after the procedure that is dependent on clinical characteristics, specifically the atherosclerotic and overall frailty profile. So periprocedural conduction abnormalities requiring permanent pacemaker implantation and development of new bundle branch block are the most common complications. But it's important to know that many patients with aortic stenosis have some conduction disease already, but the close proximity of the atrioventricular conduction system to the aortic valve apparatus makes it especially susceptible to injury during the procedure. Okay, so now specifically about the coronary occlusion. Obstruction, it occurs during or immediately after the procedure, and it is a rare complication. The incidence rate reported is between 0 and 1.2%, and tends to involve the left main stem more frequently than the right coronary artery, as happened with Dr. Kittleson's patient. So the clinical manifestations occurs immediately in 88% of patients. And in few cases, a migration of the aortic valve with subsequent obstruction is described within the initial 48 hours after implantation. It is associated with a mortality of up to 50%. And the bulky calcification of native leaflets can be the base of obstruction by occupying part or whole coronary ostium, either by leaflet displacement or by fragmented calcium debris. So clinical manifestations can range from severe persistent hypotension and malignant ventricular arrhythmias up to cardiac arrest. And immediate action is always needed, and angiographic assessment of coronary patency is required. And emergent PCI is considered the treatment of choice. In Dr. Kittleson's case, there was a delayed coronary obstruction, which is very, very rare. I actually found like 2 cases of that. And Dr. Kittleson, would you like to make any observations or add any information to this?
That was so beautiful. Honestly, I'm a big believer in the attending physician should just not reiterate to talk for the sake of talking. That was fantastic. I think that was just such a lovely overview for everybody, including me. So thank you for that.
Yeah, amazing. We're getting close to the end now. And does anyone have any questions? If not, I want to thank everyone for being here. This was such a great time. Thank you again for being here for the 3rd time, Dr. Kittleson. It is always just such a delight to have you here. And thank you, Maima, for hosting this session with me. So I'll see you soon.
Thank you, Dr. Kittleson. Thank you, everyone. Thank you, Laura.
Thank you. Bye.